Good afternoon, everyone. In the next 30 minutes, I will deliver about the topic of the dealing with compromised renal function in a patient with renal function. As a clinician from the public regional hospital, I think my talk will be the simple, real, and applicable for everyone. First, I would like to acknowledge HIV-NAT and the patient will permit their photo and their story for the presentation. I think everyone familiar with this slide that there's an emerging of the comorbidity in the HIV patients. 30% of the patients are the renal dysfunction. And this is a slide that demonstrates that they are the abnormal of the glomerular kidney function. 50% are tubular kidney dysfunction. And the GFR less than 90 cc per minute is nearly 30, 35. And the risk factor are the older age, diabetes patient, hypertension, and viral hepatitis. Fact number 2, that most of the ARVs are nephrotoxic, especially the tenofovir that we often use, can cause the acute renal failure, Fanconi syndrome, hypophosphatemia, and nearly all of the ARV are nephrotoxic. In year 2010, in its literature demonstrate that the ARV most common nephrotoxic is tenofovir, indinavir, atazanavir, and even lopinavir that we often use. The fact number 3, tenofovir was proposed as a recommended ARV. I think nearly all guidelines now, tenofovir-based regimen are first-line drug recommended. Even you work in the lower middle-income country. In Thailand, the tenofovir is launching in August 2006, and have the combination, fixed dose combination as a FTC, tenofovir, and efavirenz. The first guideline in Thailand in 2008 mentioned that we keep the tenofovir just for the second-line drug after failing the NNRTI-based regimen by using it with the PI, tenofovir PI, for the salvaging or after failing the first-line drug. And for the first-line drug, at that time in 2008, we preserved just only for the patient with the HBV and HIV, and alternative after the patient could not tolerate AZT and the D4T. In 2013, we shift the tenofovir to be a first-line preferred, and for the second line, it's still used as the same, tenofovir and the protease inhibitor. This is a scheme to show that we are work in the limited ARV choice in our practice. This is a scheme for the National AIDS Program of Thailand. We use of the NNRTI, and for the PI, we have only the lopinavir as a first-line PI recommended. And after intolerant the lopinavir, we use the atazanavir. And darunavir is preserved for the third-line drug. And you can see that the abacavir just available in the National AIDS Program in Thailand in April 2016. And leupivaline also just available in our National AIDS Program in 2016. For the tenofovir 300 milligram, first launching with the is a Vilat from the Gilead company, and followed by the Mylan. And we have the Thai government pharmaceutical start launching later. And when we make this form, we ask the GPO to have a bag that we can split or divide the tenofovir to be a half dose. The 300 milligram once daily is recommended. But whenever the patient have the clinical less than 50, you have to be careful and adjust the dose to be only the 50%. That means it's one tablet every 48 hours, according to the label of the drug company. And if the patient have the clinical less than 30, the dosing will reduce to be only 300 milligram twice weekly. It's a pity that, from my feeling, that all the fixed dose combination of the tenofovir was fixed in with the 300 milligram only. So when you use a fixed dose of the tenofovir, like the Truvada or the Tivia, you have to be careful that the dose that you provide to the patient is 300 milligram. So let's start with the first case. I want to use the alum. Okay, this is the case of 41 years old man and have the initial CD4 is 20 and 2%. His baseline lab is okay. The creatinine is on 0.9. The LV start with at that time is a 2TC tenofovir and efavirenz. After 11 days of the treatment, his BUN creatinine rising from 0.9, his creatinine up markedly lost to 5.6. So this is my question. In your practice, how often that tenofovir causes acute renal failure like this case in the first few weeks? In the first few weeks, even in the first month, it's very rare or possible or more than 5%. In your practice, I think there is no answer well because in the literature did not mention about it. Okay. So it is very, very rare. Everyone thinks that it is less than the 1 in 1,000 or 1 in 1%. I think it's similar with my practice. In after launching in US FDA approved in the year 2001, 26 October, in the following year, there is a Fanconi syndrome report with the renal failure induced by the tenofovir as a first case report in the American Journal of Kidney Disease. And in the same year, they also have a report of the acute renal failure associated with the tenofovir, evidence of the drug-induced nephrotoxicity. And even there is in following year, there is also, but the case is very rare. And all of the proof case, the renal biopsy just show is a proximal tubule atrophy without the glomerulonephritis. So in this case, we off tenofovir. And we can follow his creatinine is reduced day by day. And only the day 4, it dropped from 5.6 to 0.7. I think I need a call. จะใช้ arrow ไม่ติดนะจะได้ชี้ได้สะดวกจะใช้ arrow โอเคไม่ได้sorry the space is very limited for using the mouse. Okay, it's reduced from 5.6 to 0.7 within 4 days. And after we treat him we switch the tenofovir to isatibase, the TTC, and it's already 8 years on this regimen. His creatinine is still less than 1. So for the acute kidney injury, there is a number of the medicine that we are very familiar with the knowledge of the indinavir can cause a crystalluria and atazanavir. And we have to avoid and have the food intake. The tenofovir, there is evidence of the acute tubular necrosis ischemia and also nephrotoxic. Okay, the case number 2 is a male, 37 years old. His initial CD4 is 1%, very low, and have the opportunistic infection with the MAC. And we started him in last 14 years with the D40, TTC, and efavirenz. His CD4 up, and Kerin can maintain, but he developed virological failure with the viral load over 63,000. So at that year, we practiced by using the double boosted PI on the year 2006, and we can suppress his viral load. But after we counseling him that the theory of the double boosted PI is not different from the single boosted PI, but he prefer to be confined with the double boosted PI. So we put him in the double boosted PI as he like to have. And after 12 years, his creatinine is okay, it's 84. But when there is no indinavir available, phosphorus withdraw from the drug company. So we shift him to be the 3TC, tenofovir, and lopinavir with the baseline creatinine is 86. After 22 months with this regimen, his creatinine reduced from 86 to 70. So my question is that in the patient we have a decline of the GFR from 86 to 70 with the full dose of tenofovir, TTC, lopinavir. What will you do for him? Adjust the dose of tenofovir and consider abacavir. Of tenofovir and follow the OLE study by using only 3TC or lopinavir or other. Okay. Similar with me, so it means that we are working in the developed country that we have no choice. Just only adjust the dose of the tenofovir. And we reduce the dose of tenofovir to 75 and further reduce because we could not maintain or restore the creatinine up to 86. Even we reduced to 50%, the creatinine only 71. So if you can remember, I told you that in January, the abacavir not available in the national program. It's just available in the April. So in November, we decided to use the abacavir, and we performed the HLA-B 5701, and lucky it's positive. So we further reduced the dose of tenofovir to 40%, and the creatinine is still at 76. My question is, after using tenofovir only 40%, we could not maintain the creatinine or restore back to normal. The HLA-B 5701 is positive. If you work in the National AIDS Program of Thailand, what will you plan for him? Adjust, further reduce the dose, or test the abacavir, even if the HLA-B 5701 positive. You shift away from the tenofovir and using only 3TC and lopinavir, or you will try the integrase transfer inhibitor by asking the patient to pay by themselves or other. Please vote. No song. Really? So there's even someone that want to try abacavir. I think that maybe someone want to challenge this patient with abacavir, and mostly will shift away from tenofovir and using the 3TC and lopinavir. In this case, just to remind you that in the patient who use the tenofovir with lopinavir, the area under curve of the tenofovir will increase up to 1/3. All of the PI will have the drug interaction with the tenofovir. And we have the choice because just last year in the COI study, in the ANRS 167 Lamidol study, mentioned that the switch of to the dolutegravir and 3TC in the subclass virus triple R can keep the patient have the efficacy with the viral load suppressible. This is maybe one of the choice if you have a chance or if your patient can support. The third case is a male 44 years old. It's again my old case, 14 years ago with the high CD4, creatinine 1. And the first regimen is D40 3TC indinavir at that time. And after developed lipodystrophy, we shift him from D40 to 3TC. And we learned by following year that his creatinine was rising, and the ultrasound demonstrated of the kidney stone and hydronephrosis, the parenchyma echo with the kidney stone. So we removed the indinavir to efavirenz, and the creatinine is not improved. We have to adjust the dose of the DDI and 3TC by using according to the label of the drug. With the creatinine clearance less than 30, the 3TC is only 2/3, and that means 100 milligram per day, and the DDI is 50%. His second ultrasound we have shown the renal stone with the obstruction. So we decided to perform the light nephrectomy, but we could not restore his creatinine clearance so much, just only maintain with the 34.9, something like that, with the adjusted dose of the NRTI. So my question then, if your patient, after more than 10 years of the adjusted dose of 2TC, DDI, efavirenz, and his creatinine clearance not so bad, maintained with the 35 cc per minute, you will accept the ARV not change, or you will change DDI to abacavir, or you will use a 2TC and PI, or you use a 2TC and integrase stand transfer inhibitor. There is some that accept no ARV change, and some want to change it to the abacavir. So in this case, just to remind you that in the compromised renal function patient, you have to carefully adjust the dose. When the creatinine clearance less than 450 and even less than 30 for 2TC, we often use, but there is a mistake that they never reduce the dose of the 2TC in the compromised renal function patient. The last case is a female, 40 years old, with this one, and she was treated in the district hospital with the first regimen with giprovir. That means the D40, 2TC, and nevirapine, and after failure, we shift to 3TC, tenofovir, and lopinavir. Her body weight is 39. So do you agree with the Savacheng regimen in the developing country with the 3TC, tenofovir, and lopinavir? Of course, because I work in the limited resource, or no. After failing the first line in NRTI base. Of course, I think everyone often practice like this. We use 3TC, tenofovir, and lopinavir in the failing NRTI. In this case, after we use 2TC, tenofovir, lopinavir from the district hospital, her creatinine clearance reduced to 56.4 to 22.0 within first 6 months. And she developed the clinical picture of the Fanconi syndrome with the low phosphate, low kidney, low potassium. So if the decrease of the creatinine clearance from 56 to 22.6 with the evidence of Fanconi syndrome. So you adjust the dose of tenofovir, or you will switch tenofovir to abacavir, or you use other method to treat her. Everyone will switch tenofovir to abacavir. So that means that abacavir is very essential to take care of the patient. We switch tenofovir to abacavir, and you can follow her clinical. The body weight is increased month by month and return to normal in the 5th month, and the phosphate is the first parameter that improve. And finally, the clinical length is up to baseline of the nearly 60 from 21. So this case, just to remind you that only the creatinine, you could not use it. You have to calculate the clinical length, especially in the female old age patients. And the creatinine is not enough measure for the renal clearance. So in conclusion, dealing with the compromised renal function patient, I just to remind you that tenofovir can cause the acute renal failure in the first case that I demonstrate, though it is very rare, but it can cause. And the second point is that whenever you use a tenofovir with the PI, there is a drug-drug interaction. 1/3 of the area under curve of tenofovir will increase by the PI. And the third point is all NRTI except abacavir need the adjust of the dose that I demonstrate you in the third case. Be careful, use prescribing the NRTI. And the last point is that the creatinine is not the measure for following or monitor the kidney function. You have to monitor the declination of the clinical length and the tubular function. So this morning I just asked the staff from the Gilead company, whenever the TAF will available in Thailand, he said that not before the end of this year, and the price is in the regimen that contain the TAF is 3 to 4 times above the tenofovir base. So I think that we still have to work with the tenofovir, and we have to follow very cautiously. And even the label of the drug company start with the 50 cc per minute of Kencalen. I myself prefer that we have to be careful with the patient with less than 60, and you have to screen the parameter of the renal function since the first month, and pay attention to the creatinine clearance, declination, and proximal tubular defect. Thank you very much for your attention.